Well, welcome everyone. We're going to be doing neuro-op cases and complexities. The best of the rest tonight's going to be Dr. Joe Sowka as our presenter. I think most of you know Joe, but Dr. Sowka is an attending optometric physician at Center for Sight in Sarasota, Florida. This is a large medical surgical practice where he focuses on glaucoma management and neuro-ophthalmic disease. And I'm sure we're going to see some of those cases here tonight. Joe is also the residency education coordinator at Center for Sight and the director of optometric business development for USI. Joe was formerly a professor of optometry at Nova Southeastern University College of Optometry for 28 years, where he served as the chief of advanced care service, director of glaucoma service, and the program coordinator and supervisor for the ocular disease residency. Dr. Sowka is a founding member of both the Optometric Glaucoma Society, the Optometric Retina Society. He is also the founder and former chief of neuro-ophthalmic disorders in optometry special interest group for the American Academy of Optometry. Dr. Sowka is a glaucoma diplomate of the American Academy of Optometry. In 2021 and 2022, he was ranked number 4 by the U.S. by Newsweek magazine, America's Best Eye Doctors list. Joe is a colleague, friend, partner, and co-worker of optometric education consultants. Joe, please listen closely. Listen as the audience gives you a big round of applause in this synchronous virtual platform. It's all yours.
Thank you, Greg. Tonight's topic, neuro-op cases and complexities, the best of the rest. And we have been doing these webinars, and sometimes we get a little bit ambitious, and we don't finish everything that we start out to. So, kind of culling from previous talks and just finishing things that we haven't had a chance to talk about before. Now, in the last 24 months, I've been a consultant or an advisory board member for some companies. Got no financial interest in any products that may be mentioned. All relevant relationships have been mitigated, and with Greg, I am a co-owner of Optometric Education Consultants. So let's just talk about some cases. And I did talk about some of these at a previous lecture, but I ended up going a little too fast. We ran out of time. There's a lot of good learning here, so I'm going to tread over a little bit of old ground. Some people may have heard it, but we have a lot of new people here. And here's a case. A patient complains of difficulty with driving. He's a 52-year-old male. His last eye exam was about 2 years ago. He was not dilated. He saw one of my colleagues in Center for Sight, and he had told her that he had noticed peripheral blind spot, more so in his left eye than his right eye, mostly when he was driving, but really had not noticed any overall change in acuity or any other daily activities other than driving. And his glasses don't seem to improve his blind spot. He's 20/20 in each eye. There's no relative afferent defect. Cup to disc ratio is 0.2 by 0.2. Nerves are pink and distinct. And my colleague did a full field 120-point screening. We see that there's what appears to be relatively profound loss. There's only a few points he actually saw in either eye. And there really isn't a lot of pattern here, to be honest with you. I look at this and it seems as though there is a lot of actual nasal loss, more so because more points are being tested nasally than temporally. So, Greg, that brings me to polling question number 1. What's the most likely cause? Is it glaucoma? Is it a brain tumor? Is it malingering? Is it a congenital issue like an optic nerve hypoplasia? Or do we have something maybe like a disc drusen? And while these are coming in, Greg, have you or are you going to launch the handouts?
I will launch the handout. I was wishing everyone a happy 2023 in the chat.
Very good. Excellent. Very nice, Greg. So I will just back up while you're doing this. and show you the fields again. Now, if there's anything you can't see, just right, well, actually, left click and drag on the top and just drag it out of your way. So we got this profound loss, both eyes, and a person who's 20/20 and otherwise very, very functional. Most likely cause glaucoma, brain tumor, malingering congenital issue. And it's always been like this, or maybe he has something like disc drusen. Okay, Greg, I think people are beginning to slow down a little bit, so.
We're sharing the results.
Okay. So some people are saying brain tumor, some people are saying malingering. I think it's really easy to call some of this malingering if you look at that kind of field. It's very, very patternless. Glaucoma is a 0.2 CD ratio. I think people may be picking brain tumor because of the topic. All right.
Joe, I'm going to make a comment. I see someone on, and
Yeah.
obviously not everyone is here, needs CE. We allow people to listen, but I see a phone number, and I'm going to get a thumbs up from Vanessa here. The phone number ends in 3454, and just make sure you're on as with a camera or logged in with some type of viewing device. Because I think that's what is needed. I don't want you to not get credit. So, Vanessa, is that correct? Thumbs up. Okay. Yep. She's giving thumbs up. All right. Sorry, Joe. I want to make sure that
No
person
worries.
gets credit. So,
well, when she felt uncomfortable and she said, I feel out of my element. Will you ask me to see the patient? I'm happy to do it. So when we start doing this, we have a threshold perimetry, this is what we see, and there is some profound loss. And I guess tell us, or we should think about what is polling question number 2. So what's the next step now that we have done these visual fields? Threshold perimetry. Do we order neuroimaging? Do we send immediately to the emergency room? Do you refer non-urgently to ophthalmology, or dismiss him because the fields don't match? He's probably malingering. So we'll let people weigh in.
the handouts in the chat box for those
Thank
who
you,
need
Greg.
it. Yep. It was in the email before the webinar started, about 15 to 20 minutes. It'll also be in the post-event email tonight.
Excellent. All right. I think we got quite a few people in there. So share the results. Most people want to get neuroimaging. Some are going to send immediately to the emergency room. We'll talk about when and how to do that. Refer non-urgently to ophthalmology and dismiss him because the fields don't match and is likely malingering. Malingering is a term that is hard for us to use. Malingering implies, they're seeking some sort of gain, and we don't have the wherewithal to really assess that. People who have psychological or hysterical vision loss or anything that we're not psychologists. We can't assess that. All we can say is the vision loss appears non-organic. But we take a look at this. If you're looking for the pattern deviation, it's not helping you at all. It's not there. But if you look at the grayscale, which I always tell you to do because it shows you the neurogenicity of patterns, we have profound field loss, but we can see there is a left-sided defect. And this is a person who is driving and has to look to his left or at the side view mirror. He is going to be having problems. So this is exactly the kind of person that we need to get neuroimaging on. Now, is it emergent? The answer is no. We don't know how long this has been going on. So on a brain MRI with and without contrast, he has a fairly substantial suprasellar mass. There's compression and displacement of the chiasm, displacement of the midbrain. There's some mild hydrocephalus. Differentials included macroadenoma, cranial pharyngioma, epidermoid cyst, mild hydrocephalus. Keep in mind that what you're looking for, we all learned that pie in the sky, pie in the floor. It doesn't always have to be in that area. It could be, a mass could be elsewhere, shifting the brain and causing compression of those visual structures. So we're looking for anything up there. So he did have a tumor. He underwent a craniotomy with near complete removal of the tumor. He has been somewhat lost to follow-up. I don't know. I hope to get him back sometime to see if actually his visual field improves. But I've got two messages from his spouse thanking me for finding his brain tumor. Now here's a case that still has a little somewhat unresolved for me. And we're going to call this one bad cataract surgery, because that's what he thinks has happened. He's a 68-year-old male who had cataract surgery in March of last year. He developed the posterior capsular pacification, for which he was yagged, and really didn't feel like he did any better afterwards. And I don't know about you, Greg, but I hate it when somebody goes for a yag to come back and they say it's no better. It just doesn't make sense to me.
Right. Yep.
But he's 22. Good.
Nope. I was just agreeing.
Yeah, I hate those things. So he keeps saying his vision is worse now than before surgery. And he thinks that something has gone wrong. Bright lights bother him. He's missing letters when he reads. I actually just clipped this right out of his chart. And by bolding it, I think my text are trying to tell me he's kind of yelling about it. He feels the surgery was botched. So the OD who was co-managing referred him to our retina department. They looked at him. They said the exam is normal. A couple of drusen, a couple, mild VMT, a few RPE changes. Said there's maybe an old non-arteritic ischemic neuropathy, and because he found something on confrontation field, and referred him for a neuro consult, which was me. The retinal specialist referred all the neuro in their practice to me to look at. And this is what we have. And we take a look, and he clearly has a very, very dense right-sided hemianopic defect. So when I saw this, realized, and I'm still trying to explain to him, and it's not your cataract surgery. The cataract surgery is fine. You're missing letters because you're missing visual field. So this is, again, exactly another kind of patient we have to neuroimage. It's going to be a brain with and without contrast. It was not urgent. Conclusion: a supracellular lobulated cystic lesion. It is predominantly to the left, exerting mass effect on the left optic pathway. There is a midline shift, which is actually very, very bad. 1 more millimeter of midline shift, and this is an emergency where the person can actually die. Now, my challenge here is he's got a mass lesion, it's probably a supracellular arachnoid cyst, but I've been having a heck of a time trying to find a neurosurgeon to take out this mass lesion. And that's probably one of the challenges I've been having in my area, is getting a good neurosurgeon to take out my brain tumors for me. Now, here's a case of the disc hemorrhage. He's a 33-year-old male who complains of occipital headaches for about 4 months. He's got a little visual aura with his headache, which does sound a bit like a migraine. It worsens when he stands after sitting. He was actually a dental student when I was at the Nova University in our dental school. He'd sit all day in class. He stands up, his headache got a little bit worse. It's kind of chronic daily. It was relieved by sleep. He denies vision loss, nausea, no double vision, no pain in eye movement, no behavioral changes. He went to our medical school where the family medicine department did an age-appropriate physical, which was normal, and he was sent by the primary care physician for an eye exam. It's the three most common things that I see coming from the PCP is headache, vertigo, dizziness. And I always tell patients it's almost never, I mean, dizziness and vertigo, it's never the eyes. Headache, maybe, but generally speaking, not. So he actually saw one of my residents, and we take a look, and he's 20/20 with mild myopic correction, pupils, earrings, confrontation fields are all normal, biomicroscopy is normal, pressures are 12. He's got some nasally obliquely inserted nerves. If we look around here, there is no obscuration of any vessels at all. You've got a very well-defined small cup. But you have this hemorrhage out here, which is fairly close to the optic nerve. And I got called in as a glaucoma consult as this being a disc hemorrhage, but Greg, I have to disagree. There's too much space in here. It is not really emanating from the nerve, but there is a hemorrhage. And these are the visual fields. We look at and everything comes
Joe,
up.
I think that's
Yeah.
a good point. Why don't you echo that again? That's a great point there. Because we do, that's in that glaucoma prone zone, right? You would think that is, it's normal tension glaucoma, but it's not really all the way back to the disc. So that's a great point. So why don't you just echo that, because I think that's just worth echoing.
It's right about there. And there's a little bit of area right in, that's about the edge of the disc. So it's not really emanating through. And if this were truly a resolving glaucomatous hemorrhage, I would probably see a small dot right there. It doesn't clear from here on out. I'd probably see something still on the optic nerve. So even though there is a brief suspicion of glaucoma by others, this is not it for me. And the visual field is perfectly normal. Now, if you look at it, one might say, well, there's a little white center in there, and maybe this is a Roth spot. Maybe that Roth spot is indicative of some sort of blood dyscrasia, and that's something we should also consider. Brings me to polling question number 3, Greg. What's the next step? We do a serological evaluation of the hemorrhage. We do glaucoma therapy for this hemorrhage. We order neuroimaging for the headache, or bring him back in 3 months to see if the hemorrhage is gone.
Nothing's in the chat box. Remember, everyone, if there's any questions or comments, or you want to weigh in, that's the synchronous virtual part. You can put that in the chat box. I'll police that for Joe.
Thank you. So do we do serology, look at the hemorrhage? Do we do glaucoma therapy? Do we image him for the headache? It's just a small chronic daily headache, and it's relieved by over-the-counter analgesics and sleep. All right, so a lot of people want to image him. Some people want to do a serological evaluation. Nobody wants to do glaucoma therapy. Thank you very much. Bring him back in 3 months to see if it's gone. Oh, that could be, but had he come in 2 weeks earlier, 2 weeks later, who knows what that hemorrhage would have looked like if it was even there. All right, well, I actually co-managed this with the internist, or referred him to me, and we actually ran into each other in the hall, and I mentioned it when we started talking about the case. I said, would you like to co-manage him with me? He said, sure, absolutely. So we stood there in the hall, we went back and we had a discussion. He's writing all this down. We got to look for infectious diseases. We got to look for dyscrasias, blood cancer, a lot of things we have to look for, infectious disease. And we're just about done. And I made the comment to him and said, we'd be crazy to do any of this without, neuroimaging, because he does have headache. And he goes, yeah, I'll get that as well. And we did that. And he had a very, very large mass in the frontal parietal region. This is not him actually, but very, very similar. It's huge mass causing midline shift. See how this actually is shifting it over past the midline. And this was a very, very ominous situation. My colleague, my friend, the internist, he got he got a call that, on a Friday night from a radiologist. And I can tell you, when you get those calls, it's never good. And he was able to get him admitted to the hospital that night, and put on anti-seizure medicine and steroids, because he was really in a severe risk of having a major seizure. So he had this all taken care of with surgery. Now, what was the key here? He had a posturally changing headache. And that is a type of headache that we have to worry about. When there's a postural change, if there is headache with nausea and vomiting, or vomiting without nausea, these type of headaches that occur with orgasm, headaches that occur or change when they change posture, these are all bad signs that tell us we should be looking a little further and considering neuroimaging on patients like this. So he had a very, very large, think about a 9.5 centimeter tumor that was causing midline shift. Ultimately, he underwent craniotomy where it was removed. There were some mixed cells in there, so he underwent 2 rounds of chemotherapy. He had withdrawn from dental school when he went through this. He actually did return to dental school and graduated and became a dentist in the Tampa area. And when this is all done, he actually went to our traumatic brain injury clinic at the university, because it's almost like he had some spatial disorientation. It's almost like a traumatic brain injury. Now, my internist colleague and I, we lectured together frequently, and we were talking about this. And we would tell the story, and he would say how this fellow, he graduated from our dental school, and he had a successful practice of dentistry in Tampa. So we always told that story. That was the outcome. And then when I talked about this, I always told that as the outcome. And I was talking about this with my residents in a conference. And one day I thought to myself, where exactly? Let me just look him up. I actually remember the name, so I Googled his name, and the first thing that came up was a link to his obituary. He had died a couple months before that, which was 5 years after we had diagnosed this from brain cancer. So he had recurrent disease, but he was able to graduate dental school and begin practice for at least a while, but he did succumb to his disease.
Joe, there's a comment in the box that says nasal disc blurring. I'm not sure if you want to go back and look at the disc and see if it's nasal.
No, there's no obscuration of any vessels. I looked at him live, and I can tell you, if I were to, and I probably should do this, pull up his post-operative nerves when that mass was gone, it looks exactly the same. It was just nasally obliquely inserted. So a pearl to remember, a normal visual field does not mean that there isn't anything wrong. Let's talk about that. Whenever we hear about headaches, we worry about something, we do a visual field. And if the visual field comes out normal, we feel vindicated, we're good. But it's not true. If it's not impacting the visual system, nothing's going to show. He had a massive brain tumor with normal visual fields. Or what a lot of people want to do is they want to do a full field 120 point screen. Get off it. Don't do those screeners. They don't give you any good information. If you want to do anything, 24-2, I don't think 30-2 is any better. 24-2, see the fast, see the faster. Neuro-op is not subtle. It's not like glaucoma looking for an early defect. See the fast, see the faster, that's good. 24-2. It's going to find as much as it's going to find a 30-2. Don't worry about the full field screening fields. They don't help.
So I guess a way to kind of say it is the whole brain does not take up the visual. And I think there's the number that I remember is about 50% of the brain has visual fibers running through it. So the pathology could be in the other 50% is what you're saying, Joe. If that number, I think I'm pretty accurate with that number, that the brain has fit in, from the eye to the occipital lobe, 50% of the brain is occupied by
Mhm.
visual fibers. So that pathology could be in the other 50%. So it's not going to affect the
Mhm.
visual field.
Yeah. And we're trying to tell a radiologist where to look. Keep in mind, what you're looking for may not be in a parietal. By the way, lesions in the parietal lobe tend to cause visual auras. So that's another clinical pearl. And I think we all learned that pie in the sky, temporal lobe lesion, pie in the floor, parietal lobe lesion, it does matter. They're most always all clinically, they're all parietal lobe lesions. And if you tell them exactly where to look, don't be surprised there's something somewhere else causing shift that's causing the affect in the visual system.
Yeah, and that's one thing I've learned, Joe, and then probably most likely from you, is that, I work with, 611 MRI in my area. And I say, look, I got a pie in the sky, pie on the floor, left side, right side, parietal, temporal. I say, look, there's some type of pathology causing damage to this area. That doesn't mean that's where the issue is residing. So that's another good pearl to point out, but we do know that it's affecting that area. Charles Goodman here has asked, what if the hemorrhage had not been there? I think that's a great question.
I can tell you a ton of things, woulda, shoulda, coulda on this one. If I had stopped at the restroom, I would not have walked past this internist in the hall. We would not have had this conversation. I think the key here was the headache. All right, now, if the hemorrhage had not been there, I might not have been called in. My resident may have dismissed the patient. We don't know. Sometimes it's better to be lucky than good.
Yeah, and I think in this one here, I think another pearl is that posture change. That's what I've learned over the years. If the people are sitting there and they're like, man, I just need to stand up to get my headache better, I don't care how normal that exam is. It's probably almost Pavlovian for me to say, okay, we're going to get this person imaged. So,
all right, I'm going to call this one migraine squared, because he was a migrainer who got diagnosed with a migraine. He's a 39-year-old male, previous history of migraine. He develops a new and worsening headache. Goes to an ER where he gets admitted for 3 days. He undergoes a non-contrast enhanced CT and MRI, which was subsequently interpreted as being normal. His headache was attributed to migraine, and he was medicated with a new migraine medicine and discharged. So here's a migrainer who tells you it's a different type of headache. Now, 3 days after release, he develops horizontal and vertical double vision. Now, when you send patients you send them to the ER, you think that they have the same skill and knowledge and training and experience as we do. They don't. They're very smart. But this is your typical ER physician encountering a patient with an eye problem, right? And she just has conjunctivitis. They don't want to get involved in this. If you can help them, you're going to help the patient along to a possibly better outcome. Now, this is our patient here. We can see he's got a little bit of a ptosis on his right side. He cannot adduct his eye, and he cannot abduct his eye either. So we have an adduction, elevation, depression, abduction deficit with a bit of a ptosis. Pupils were normal. Now, I actually didn't film this. This is one of my former residents had filmed this. Can it adduct? Doesn't elevate very well, doesn't look down very well, and he cannot abduct. Okay. Are you hearing anything, Greg?
No, nothing's being
okay.
no
So
sound
I'm
coming
hearing.
through.
I'm hearing. That's okay. But we see his motilities. Okay, so his visual acuity and fields were normal. He has a right pupil sparing external partial cranial nerve 3 palsy and a concurrent right 6 nerve palsy. He complains of worsening headache and lethargy. Where is the lesion? This is now where we have to remember our neuroanatomy. The thing gives me to question number 4, Greg. Can you launch that? I'll give the information back here. And like I said, if you left click, you can drag that pole out of the way. Acuity and visual fields are normal. He has a right partial third nerve palsy and a right sixth nerve palsy. Is a lesion in the orbit? Is in the cavernous sinus? Is it somewhere in the brain? Or I've got no bloody idea. That's why I'm here to learn. It looks like we've cleared the chat so far, so we're good, Greg?
Yes, that's what I was just looking. I was replying to a message and looks like we're at a nice percentage here. So I'm going to end the poll,
Very good.
share the results, and there they are.
All right, so most people are saying cavernous sinus. Some people are saying somewhere in the brain. Other people are saying orbit, and some people are saying I have no bloody idea. Well, we have to look for where 3 and 6 and maybe even 4 come together. And one place is a cavernous sinus. Another place is a posterior orbit. But in the posterior orbit, it also is the optic nerve, cranial nerve 2. His visual field and his acuity are both normal, or his visual acuity is normal, so optic nerve is uninvolved. So posterior orbit is not a likely possibility. So it kind of leaves us to cavernous sinus. So looking at that, let's contact that radiologist for a second reading. Now we're going to tell the radiologist, look at the CT, look at the MRI, and look at the cavernous sinus. That's where we're thinking that there is an issue. So he looks at the cavernous sinus and said, cavernous sinus is fine. Everything is good. And then he adds, but the pituitary gland looks a little bit chubby to me. And at that point, I said, okay, just like in the old time, TV shows where you drag the needle across the records. Okay, now we know what's going on. Set back for repeat imaging to the emergency room, contrast enhanced MRI of the paracellular area at MRA to look for intracranial aneurysm and specifically pituitary apoplexy. And now a directed scan showed he had a pituitary macroadenoma with a intratumoral hemorrhage, and he had a pituitary apoplexy. It actually had spread into the cavernous sinus and was possibly spreading into the other cavernous sinus as well. But interestingly, it didn't grow superiorly like they most will and compress the chiasm. Hence, he had normal acuity and normal fields, which is actually kind of atypical. He got immediately admitted for an endocrinological and a neurosurgical evaluation. So he had pituitary apoplexy, and this is a potentially fatal disease. It's a serious condition affecting about 10% of all pituitary tumors, and it can have an associated headache, vomiting, visual impairment, ophthalmoparesis, mental state alterations, loss of or decreased consciousness, lethargy. It all comes from panhypopituitarism. Now, these patients are hemodynamically unstable from adrenocorticotrophic hormone deficiency, and this can kill them. This is a rapid expansion, usually a hemorrhage or an infarction of a pre-existing pituitary adenoma, which the patient may or may not know of. Pituitary adenomas are very common. I'm going to say probably on this webinar, there's probably a couple people here who have a subclinical asymptomatic pituitary adenoma. Headache.
So Joe, let me ask this question because I know
Sure.
this is, and sometimes this one here confuses me. And I know that pituitary apoplexy is it's bleeding, it's hemorrhaging. Is it a blood vessel that's near, like a normal blood vessel that is the abnormal part here? Or like I know tumors, they get blood vessels, and
Yes,
is it those blood vessels that are bleeding?
Yes.
Okay.
Yeah. What happens is it bleeds and it expands that adenoma like blowing up a balloon.
So it's kind of like wet macular degeneration. So it's that's the way I'm going to remember it from here on out. It's kind of like a choroidal. Maybe it's not a new blood vessel, but it's a blood vessel from this, and it's bleeding. It's kind of like wet macular degeneration, but of the pituitary. Thank you. All right.
Yeah. But the thing is, it blows up. It increases massively in size.
Yeah.
And this is often overlooked, as the cause of these thunderclap headaches. When they go to the ER, they're going to be looking for a subarachnoid hemorrhage, venous sinus thrombosis, and a cervical artery dissection. So they don't think about pituitary apoplexy. About half these patients are going to have visual abnormalities. The big one is bitemporal defect. A new sudden onset bitemporal hemianoptic defect, headache, it's apoplexy. Cranial nerve palsy, 6 is the most common. 3rd is the next most common. They may have some facial weakness as well. So most of these people undergo a CT in an emergency room setting, which is non-contrast enhanced because they're looking for an intracranial hemorrhage. And it's usually not going to be C. Now, if there is acute hemorrhage, it may be seen on a CT, but these non-hemorrhagic infarcts where it just blows up but it hasn't really bled, usually won't be shown anything unless there's contrast. Now, MRI with contrast is the most effective imaging. If you suspect a pituitary apoplexy, it is superior to CT. This is an emergency room situation because this is a person who can die. The outcomes actually could be pretty good. Sometimes we'll do conservative medical treatment, replace the hormones, and stabilize the patient. Now, if they have visual impairments, they have neuro-ophthalmic dysfunction, double vision, well, they're going to probably be selected for surgery, and they'll undergo a transphenoidal or transfrontal, transcranial approach and remove that mass. Now, this happened during COVID lockdown. So it's really, really bad and really, really hard to get him care. He was medically stabilized with hormone replacement, and they delayed surgery until the COVID lockdown was done. And ultimately, he underwent a successful surgical decompression and has actually done very well. Now, that's essentially 4 mass lesions that I just talked about. Now, what I want to point out to you is the vision was normal in each and every case. There was vertical field loss in 2 cases. 2 cases had normal visual fields. There was headache in 2 cases, none in the 2 other cases. There was diplopia and ophthalmoparesis in 1 case, none in the other 3 cases. There was no disc pallor in any case. There's no disc edema in any case. Conclusion, mass lesions don't follow expected rules. You shouldn't think that they're always going to have headache. They're going to have a vertical field defect. They're going to have disc edema. If I can give you anything here is they don't all follow any rules. So don't expect that you're going to see massive papilledema or bitemporal or hemianoptic defects or vision loss or disc pallor. None of them had, it just is inconsistent. Would bleeding inside a benign tumor show up on a scan? Well, if it was, that was Keith's question to me. Would it? Well, pituitary adenomas are by and large benign. So if it's bleeding inside that tumor, yes, it should show up if they are specifically looking for it. We have to help them out and tell them what to and where to look. Greg, anything?
You got it.
All right.
You're up.
Well, here's one is what we call surgical issue. She's a 78-year-old female who's got a sudden onset of ptosis and meiosis immediately following parathyroid surgery. Let's talk about what happened and how this all transpired. So she comes in on a Thursday. She has neck surgery to remove 3 parathyroid adenomas. And you can see her little surgical scar right there. When her son was taking her home from surgery, he noticed her eyelid was drooping, but just assumed it was probably an anesthetic issue. He woke up the next day, her eyelid was still drooping. She calls her surgeon, and it sounds like he got very, very anxious and sent her to the emergency room because you might be having a stroke. He goes to the emergency room, and Greg, what test do they do in the emergency room?
Non-contrast CT.
Of the head, yep. And that was normal. They say, you're not having a stroke, go home. So about 4 o'clock, which is my last emergency appointment for a day. This is on Friday. She comes to see me, and I'm looking at her. She clearly has a Horner syndrome. There's a dilation lag. She's had neck surgery. But what bothers me, and I don't like this at all, is she has headache and eye pain. And I will tell you, if you have neck surgery, you should have neck pain. Headache and eye pain is trigeminal pain. That's something entirely referred and different. Now, possible causes, lung cancer. I think we learned that in what, second grade of optometry school, Greg? Pancreas
we did.
tumor.
Yep.
Carotid dissection or cervical artery cerebral artery dissection, surgical trauma to the nerve, migraine. These are all possibilities. So, Greg, that brings me to polling question number 5. What's the most likely cause here? Is it lung cancer? Is it a carotid dissection? Did they nick the nerve and, she's got a surgical oopsie here? Is it migraine? Or I've got no bloody idea. That's why I'm here to learn from you.
Rolling in nicely. I'm going to launch the handout one more time, Joe.
Thank you, Greg.
Just in case someone needs it. There it is. All right. Send. Okay, everyone. The handout's in there if you need it one more time, if you want to download it. I'm going to end the poll, share the results. There you go, Joe.
Okay, we have a lot of things. Lung cancer. We already learned that in second grade, optometry school, carotid dissection, surgical trauma to the nerve, migraine. I have no bloody idea. Now, direct surgical trauma to the oculosympathetic plexus in a person who had neck surgery goes together to me like cookies and cream. That's one that I think we're foolish not to consider that. But what I don't like is the headache and eye pain. As I said earlier, neck surgery should give you neck pain, not headache and eye pain. And my concern was a carotid dissection. So what is Horner's? It's a triad. I'm gonna caution you. In any syndrome, you don't have to have everything there. But it's a disruption of the sympathetic plexus to the eye and face causing miosis, upper and lower lid ptosis, and anhidrosis. Miosis, ptosis, anhidrosis gives you a diagnosis of Horner's syndrome. But you don't have to have all three. In fact, I can't remember the last time anhidrosis has actually come up in any situation. So we begin here, the dorsolateral hypothalamus goes down the spinal column to T1 where it synapses, that's number 1, goes up over the apex of the lung, which is where lung cancer comes in. It will synapse the superior cervical ganglion. From there, it's going to go to the sweat glands of the face. It's going to go to the pupil. It's going to go to the muscle of Mueller, the upper and lower lid. And most of the time, this right here, that's the external carotid. This is the internal carotid. It goes right along with the internal carotid artery. Now, I don't know why we were designed like this. To me, it makes a heck of a lot of sense to go from here to here instead of going all the way down here. It's like Greg. It's like you going to the neighbor's house on the right side. But what you do is you go out your house, you walk to the left and walk all the way around the block to approach your neighbor's house from the other side. And it just doesn't make sense. Now, we've had pharmacologic testing, cocaine, hydroxyamphetamine. Apriclonidine really is what we use today. It works upon denervation supersensitivity, though it will take a little time from the onset of the condition before those postsynaptic receptors become super sensitive or super starved for neurotransmitter. What I want to caution is apriclonidine is an alpha-2 adrenergic agonist, has weak alpha-1 properties. It doesn't work with phenylephrine. It doesn't work with alpha-GAN. It doesn't work with upneek. Now, what will happen is you put it in, a horner's pupil will dilate widely, the lid will come up very, very profoundly, but a normal pupil doesn't. So
Joe, let me
where,
make a little
yeah.
clinical pearl here is that
Mhm.
there's a few things that I like to keep in the office. I like to keep 1% atropine for the patients that come in and have an iritis, and I can start the cycloplegium at that time. I like to keep a bottle of apoclonidine or iopidine in the office, along with, some Diamox. So a little clinical pearl out there is, like Joe said, a lot of times we have samples of alpha gam, but that is not going to work for this condition. So,
Mhm.
we keep a bottle, it probably expires before, which is okay because it just gets weaker. And then maybe the patient is going to be even more sensitive to it if it's if it's 5 years expired, I'm not going to use it, but it usually expires and it's not that expensive. So my point is, keep a bottle of apoclonidine, keep a bottle of 1% atropine, and a few Diamox tablets in the office.
And by the way, just as another clinical pearl, these patients, when the evaluation is all said and done, I do prescribe aproclonidine for them to be used like once a day as necessary. Sometimes they use it for social engagement. It really works. It's inexpensive. I think everybody tells us it's like about $9. I'm not sure if that's with or without insurance, but it's not very expensive. So first order up here, you can have stroke, tumor, MS, demyelin disease. Second order, you can have the lung cancer, the Pancoast tumor. Third order, going from here to here, we also used to say that was benign. We didn't worry about it. Well, it's not really true. Cluster migraine can do this. Paratrigeminal syndromes can do it. Dissections can do it. There are a number of things that can do it. Doesn't matter. Anywhere here in this pathway, bad things can happen to our patient. And what we have to really consider and worry about is a carotid dissection. All right, these patients present with a sudden or gradual onset of neck or a hemicranial pain, facial pain, eye pain. It can be post-traumatic. It's been reported after roller coasters, whiplash, chiropractic manipulation. One of my former students who will probably, or I'm hoping will become my resident next year, underwent a chiropractic manipulation, developed a cerebral artery dissection, almost died from it. Post-surgical neck dissection, endarterectomy can do it, or it can happen spontaneously, where all of a sudden you might, our friend Robert, our internist friend, he was working out in a hotel gym and heard a pop and he had a headache and he developed a carotid dissection. Now, carotid dissection is a linear tear in the vessel wall, and what happens is blood will coagulate and thrombose. So you'll get a thrombosis here. And the issue is thrombosis leads to embolus, which leads to cerebral vascular accident. Now, dissection will have other neurological findings: Horner syndrome, transient ischemic attacks, real stroke, ischemic neuropathies, hemorrhage, and other cranial nerve palsies. Now, when a person develops a dissection, of those who develop a stroke, like a true stroke from this subsequent, half will have the stroke within 6 days, 2/3 within a week, 90% within 2 weeks. After a month, you're pretty much good to go. The vessel wall has repaired itself. They don't need neurosurgery. They don't need vascular surgery. They need stroke prophylaxis. They need to be under the care of a stroke neurologist. So Horner syndromes from a suspected carotid dissection should go right to the ER and tell them what to look for and how to look for it. Now, this is a vascular disease. Whatever you're going to order or tell them to order, it has to have an A in it. A, artery, A, aneurysm, A, it has to be a CTA or an MRA to look for it. Now, why did they not find it? They did a non-contrast enhanced CT of the head. So this was actually a very long story that was involved. My concern is, they may have nicked it, but I don't like the facial pain, the headache, and the eye pain. So I'm explaining the situation. I'm telling, I think you have a carotid dissection. You need to go to the emergency room. He said, absolutely not. I was just there. They told me I was normal. I said, you need a scan. So I had a scan. I said, you had the wrong scan. Then she's a retired nurse, so she had some medical training and some knowledge. And she dropped the bomb. She goes, but you're an optometrist. And she may have actually said, you're just an optometrist. I'm not really sure. I don't remember at that point. He said, can I see one of your ophthalmologists? I said, no, there's nobody here. And if you did, they're going to send you to see me anyway. She said, well, can I see a neuro-ophthalmologist? I said, of course you can see a neuro-ophthalmologist. Can I see a neuro-ophthalmologist right now? I said, no. She says, why not? Because it's 4:40 on a Friday. I'm the best you're going to get today. That's it. She refused to go back to the ER. She got actually very emotional. She still really wasn't recovered from her surgery. I did convince her to take a baby aspirin. Saturday, I called her. She felt better, but she still had a little headache. Called her Sunday. She felt a little bit better. She's getting over her surgery, but she still had headache and eye pain. Now, on Saturday, she refused to go back to the ER. Sunday, she refused to go back to the ER. On Monday, she's a snowbird. I'm in Sarasota. She's from Buffalo. She calls her ophthalmologist in Buffalo and tells the situation. Her ophthalmologist said, look, I can't do anything from here. I can't order testing. Either you do what Sowka tells you to do, or don't go back and waste his time. So now I've been given the seal of approval. She, she calls me on Tuesday and says she's agreeable. At this point, we order an MRA, and she comes back and she has a carotid dissection. So I'm very, very glad that she agreed to take 81 milligrams of baby aspirin. I put her on 350 milligrams then, which is a full dose. And because I had positive imaging, I was able to get her into stroke neurology the next day, and she actually did thrive. And, she said she was very thankful. She sent me a basket of food. She was telling me, I saved her from herself. I helped her get through. Is there anything I can do for you? And I said, look, we pride ourselves on our reputation at Center for Sight. So if you're so inclined, you can leave a decent Google review. Say, I will do that. I will give you the best Google review you've ever had. So I get the Google review. It said, he was very cordial. He gave me his cell phone number. He spoke to my ophthalmologist, and that was it. But we did save her.
So
Now,
Joe,
what do you? Yeah.
I threw a question in the chat box, and maybe some people saw it. I know some people did see it, but maybe not everyone saw it. So if they want to reply, I just wrote, who has, poor English, who has a Horner's patient, or who's had a Horner's patient? What was the cause? Because the ones that I've seen, and I'm going to jinx myself because it's probably been, maybe 9 months or a year now. They've all been kind of that carotid dissection type of patient that I've had. You said about that, we all learned in second grade of optometry school that I thought every single Horner's was going to be like from a lung cancer. So I was just kind of curious, and we did have someone that said it was from a lung tumor, and then there's a congenital. We have one of our attendees here talking about multiple times and after probing history, it referred to neuro, and one looked to be like from infectious, from syphilis. And then, someone replied, seen a few times, mine were spontaneous. Maybe it was that carotid, and then lost a follow-up. So I was just kind of curious, just to, mine have been from carotid. I just kind of wanted to see what the thoughts were. What's from your end? What have you seen most?
Mostly I have seen idiopathic. And I've seen otitis media, but for the most part, it has been carotid dissection. And the whole thing with lung cancers, you think that's the worst thing? The prognosis is pretty grim. The 5-year survival is about 30%. We're not going to really affect much in that type of situation, but this is where it can save a life. And what you need to say to the ER doc is, you don't tell them they have a little ptosis and a little pupil. You say to the ER physician, this patient has a carotid artery dissection, will stroke out unless they get a CTA and refer to a stroke neurologist now. And if you say those words, they're foolish not to listen to you. But this is where we can actually intercede and save patients. Well, here's a case of horizontal double vision. 75-year-old female who complains of sudden onset of painless double vision, worse at distance and in left gaze. You can see her, she's looking in left gaze. She will adduct, but she cannot fully abduct the eye. No headache, no jaw claudication, no TIA, no weight loss. I'm not really suspecting a giant cell in this patient. She's diabetic and hypertensive. No vision change. She's 20/30 in each eye, but she does have commensurate cataracts. Fundus exam is normal. There's no evidence of disc edema. So let's just take a look here. Looking left, you don't abduct all the way. She adducts, doesn't stop, doesn't make it all. She can look up. No ptosis, everything is fine. Pupils are good. And this is actually, I'm doing an alternate cover test at distance, very important. Don't test them at near, test them at distance because we need the divergence. And it's kind of hard to film and do everything all at once. Look how the eye snaps, glides, snap, glide, snap, glide. That tells you you're dealing with something neurogenic and not restrictive. So you're doing the alternate cover test, look in the right gaze, straight ahead, left gaze, at distance, and you see that, as I said, slow, snap, glide, snap, glide, snap. That tells you we're dealing with something neurogenic. So 6th nerve palsy, horizontal, worse at distance with an abduction deficit. So make sure you're checking motilities at distance. I've had several people I've trained, residents who are standing up in front of the patient, follow my finger, and they don't really see anything because the patient's already is converging. We need to have them at divergence. This is a divergent issue. They need to be looking at distance at the chart on the wall. We can do a force duction test, put a little bit of proparacaine in there. Can you push it over very easily? The answer is yes. It's not restricted. Now, dealing with 6th nerve palsy, each case of 6th nerve palsy should be classified as either traumatic or non-traumatic. Now, the non-traumatic cases, you have to divide them as, are they neurologically isolated, meaning just a 6th nerve palsy, or are they not isolated? There's something else going on, such as a 3rd nerve palsy, a Horner syndrome, a facial nerve palsy. There's something else going on. They're complicated. And then we have to ascribe them to one of 3 groups: children, young adults, older adults. And these kind of blur together a little bit. Now, my definition of children, Greg, you can jump in here if you have anything that you agree or disagree with. For me, children, prepubescent. Up to, once they're past puberty, now they're young adults. Where does young adult go? 40 to about 50. And I hate to say it, older adults in these contexts, 50 and above. Hey, not me. Don't shoot the messenger. Don't blame the messenger. 50 above is an older adult. Puberty, before puberty is a child. Anything else is a young adult. Any thoughts there, Greg?
Yeah, I mean, from this serious discussion here, puberty, as you know, we lecture with Tracy Offerdahl, and we're trying to prescribe medications, adult dose versus, pediatric dose. Puberty is usually the answer. The other day I saw 24 patients. I added up everything. My average age was 68, and I consider someone pediatric if they're not in a bifocal. So that's
exactly. Mm-hmm. Now look at the demographic groups. Once you get those, now you can start thinking about what these all mean. Older adults and isolated 6th nerve palsy is usually not bad. You might have vascular disease, ischemic conditions such as diabetes or hypertension. It's going to resolve in about 3 months. Now, I tell the patients in 6 weeks, you're going to be much better. And in 12 weeks, you should be pretty much resolved. You should always consider giant cell over the age of 60, though. Probably, let's say maybe 50. All right, let's change that. Let's make it over 50. You should always consider the possibility of giant cell. But giant cell arteritis causing cranial neuropathies, much more common to cause a pupil-sparing third nerve palsy than a fourth or sixth. 4 or 6, in a large series, they constitute about 5% of giant cell was about 5%. Now, children, it's often bad. There is presumptively viral illnesses, could be trauma, but malignant disease is pretty high up there, 50%. In fact, about half of these patients will have a pontine glioma. So children, 6 nerve palsy that is not traumatic. Viral illness can't be proven. That's only a presumption, diagnosis of exclusion. Children with a 6, you really should be in the hands of pediatric neurologists. Young adults, it's usually pretty bad. Vascular diseases and idiopathic are not that common. But I want to tell you is isolated 6 nerve palsy in young adults is really not a common condition. They're usually actually complicated. They might have a 6 nerve palsy and a hemiparesis, or a Horner syndrome, or a 4th nerve palsy, or a 3rd nerve palsy, or a facial paresis, or a gaze palsy. There's just something else going on. And in those situations, cerebral vascular actions in the pons, aneurysms in the cavernous sinus, tumors in the cavernous sinus and the base of the pons, demyelinating disease, these are all more common. So older adults, generally not that concerning. Children, pretty concerning. Young adults, very concerning. But I'm going to qualify that. I have seen young adults in that age range with isolated 6 nerve palsies that turned out very well. Most of them in this age, they're not just isolated, there's something else going on. And they're usually bad things. So isolated 6 nerve palsy in older adults with a history of diabetes, hypertension, or other atherosclerotic disease, neuroimaging and other evaluations can be deferred unless it progresses, doesn't improve over 3 months, or they develop other complications. Now, here are some pearls to take home with you. Ischemic vascular palsies can get worse over several days, or can get worse over a week. I mean, a 3rd, a 4th, a 6th that's ischemic can get worse over the course of a week. It can be no better in 2 weeks, but it can't get progressively worse in 2 weeks. That doesn't happen. That's not ischemic. That's something else. Also, patients are allowed only to have 1 ischemic palsy at a time. You can't have a 3rd and a 6th and call it ischemia. You can't have a bilateral 6th and call it ischemia. You can only allow 1 palsy from ischemia at any one time. Those are 2 very, very important clinical pearls. So what is our outcome here? We discussed MRI, and I told us, look, if you're the kind of person you want to get imaged, I'll get it. I'll order an MRI. And to be honest with you, even neuro-ophthalmologists have not been able to agree what to do with 6 nerve palsies. Do you image all of them, or do you just watch them for a period of time? Caveat: they're older adults and they're isolated. So we had the discussion, and she was quite satisfied to not go into the tube. So I recommended that she patch her eye to improve her function. I told her what the expected course was, and I said, I'm going to see you back in about 6 weeks. Now, if you're ever wondering, and one of my colleagues had seen her first and referred her to me, so I knew she had this for a couple of weeks already. If you're ever worried, you can bring them back in 2 weeks and see if they're getting worse. You know, you got to do something else. If they're about the same, that's okay. So I set her for a 6-week follow-up. She was marked, she was about 50% improved. Her motility was better. At 12 weeks, she was great. She was of Eastern European origin, and she gave me a really nice bottle of vodka, Greg. So I was really, really happy about that. It's very nice of her.
Hey, Joe, I'm coming down in Sarasota meeting in March, if you still have it. This is a recent case, don't open it yet.
Okay. All right. So she had better at 12 weeks. So ischemic palsies can get worse over a week, be no better in 2 weeks, but they can't get worse over 2 weeks. You can only have one microvascular palsy at a time. Now, when does
Joe,
this actually become?
I think one of the things I'd like to point out is I recently had, a 6 nerve, I think it was. I was going to try and look the video up here on my phone, but it was mild. And I said, why don't you come back, because this can get worse. And it did. And, the patient was kind of, a little nervous, in a sense that it got worse, but kind of felt better that I told him that was potentially could happen. So, so I saw them early. It was a 6, I believe. I'm going to look it up on my phone here. And then it did get worse. And then just like you said, if you can give them confidence of what's going to happen here, but I think the key here, it has to be isolated, right? Make sure you ask a zillion questions like, listen, are there any other symptoms that are going on? Because like you said, if there's something else going on, then you got to figure out what else is going on. So,
and when you say, yeah, worse, Greg, I mean, you can go from a subtle palsy to not moving past midline.
Yeah.
At 7 days. But at 14 days, then you got a problem if it progresses that long. So when is it a nightmare? Well, 77-year-old male patient and his sister come in insistent on cataract surgery to our practice. Now, 2040, 2070, right and left eye, he had NS. Chronic horizontal diplopia worse over the last 2 weeks. He got an abduction deficit of about 40%. Medical history, inoperable chondrosarcoma, lysis of the clivus, left petrous apex, the temporal bone and occipital condyle, with sphenoidal, ethmoidal, and temporal bone involvement, compression of the jugular vein. It's inoperable. He's undergone about 50 radiation treatments. He's got a vocal paralysis. He's got paralysis of cranial nerve 9, 10, 12. Oh, by the way, just between us friends here, we know there's 12 cranial nerves, right? Okay. You're talking 9, 10, 11, 12. They're not in our office. They belong with neurology. In fact, you have my permission to ignore everything above cranial nerve 8. So for us, we only have 8 cranial nerves. That's all we have to worry about. So he got worse. I imaged him CT with contrast. He couldn't have an MRI because he had a pacemaker. He had new soft mass in his left nasal pharynx, likely a squamous cell carcinoma. I think more his sister wanted cataract surgery for him than he did. It was going to be a nightmare, and I just explained it to them that you've got a new mass, you got a new cancerous mass. And he said, look, I'm done. I've had 50 treatments. I'm not going to do anything else. But what's the key there? Cancer. Now, when looking for a mass lesion for causing a 6 nerve palsy, the base of the pons and the cavernous sinus are 2 common hiding places. So if you're going to neuroimage patients for 6 nerve palsy, if you think that you're doing it because you think there's a tumor, you order the brain with and without contrast with attention to ipsilateral cavernous sinus and base of the pons. That's where you tell the radiologist to look. Here's a non-ischemic one. 68-year-old male developed an isolated 6 nerve palsy left eye. The OD, who was one of my former residents, was asking about my thoughts. Is this a possible ischemic? A medical history of hypertension, and he also had a rare salivary gland cancer 2 years earlier. Once you see cancer and neuro-ophthalmic anything, you've got to consider cancer. So she's asked me, do I think this is ischemic? I said, it could be, but I don't think so. I said, you need to image the patient. And I told her where to look. And it turns out he had a malignancy in the cavernous sinus. Unfortunately, the patient was her father. So she was consulting with me on her father, who had this rare salivary gland tumor, a cancer, and he had now developed double vision, a sixth nerve palsy. His prognosis was about 2 years. I think he has gone beyond 2 years. I just spoke with her a little while ago, communicating with her. She was telling me that she had a baby, he saw his grandchild, and they consider every day to be a gift at this point. But again, the key, cancer. Now, if you're watching a presumptive ischemic sixth nerve palsy and you're wrong, it's not ischemic, it's something else, you really probably haven't hurt the patient. There's no aneurysm out there that's going to pop and kill them, not like a third. The vessels, the nerve and vessels are separate. That's not going to happen. And if it's something that's going to kill them, it's going to kill them anyway, whether you diagnose it this week or 6 months from now. So if you're watching something you think is ischemic and you're wrong, you probably haven't hurt the patient. Now that's a lot of stuff to remember. So I'm going to leave you what I call my ode to a sixth. When the double is side by side and abduction does not abide, prove it's a sixth with a forced suction test, limited muscle, thyroid, and all the rest. In kids and young adults, it's a worry. Get a scan, you better hurry. But in an oldie, you're practically free. Prescribe a patch and check to see it's better in 3. And if you remember that, that's all you need. Greg, anything going on up there?
There's a question that came in about 4 minutes ago. It says, if you decide a patient needs an MRI, what do you ask for? MRI brain with contrast?
If you're talking sixth nerve palsy, the answer is yes. When you request the MRI to look in a certain area, do they take more images of those areas, or that's mostly just for the radiologist? They have a standard algorithm they go through. But you're helping them to look for something. You're like, over there, quick, over there, to your right. That's what you're saying. You're giving them the clue where to look. But they're not going to focus the radiation there. 25-year-old woman
Hold on. Another one just rolled in.
Okay.
Similar to the conversation. So when you request with the MRI/MRA to look for a certain area, do you take more images in those areas, ? Or is it just for the radiologist?
No, we just went through that. That's just for the radiologist, so that she or he knows where to look, and to really pay attention to when they go through those cuts.
Yeah. So what I would echo here is, like I mentioned earlier, I use an MRI unit in town, and usually it's a team effort. It's not just write an order and take it over. It's more or less, I usually talk to Joe, and then I call the neurologist, and then don't always talk to Joe, but most of the time. But then it's a conversation with the neurologist. Hey, this is the symptoms. This is what they came in with. This is where I'm looking. This is where I'm thinking. Left side, right side. And the neurologist or the radiologist really loves that, right? They're not flying by the seat of the pants, relying on what the patient is saying, explaining like, hey, I'm going to send this patient over now. They're dilated. Their pupils aren't blown, or so on and so forth. So the best thing to do with this is just be a teammate. Just like Joe said, he was talking about that dentist student, and it was just happened to be a conversation in the hallway. Be a teammate; they'll love you for it.
Now, this is a 25-year-old. That's great. That is a great addition. Thank you, Greg. 25-year-old woman involved in a minor automobile accident where she's hit by another car. Very minor. In fact, what I envision like bumper cars. If you remember the old bumper cars, boom, you get a little shock. That was it. No injury to either driver. Both cars were driven away. Only a mild to moderate bump during the accident. No head trauma, no eye trauma, no loss of consciousness. Wake up next morning, she had profound double vision. So what do you think is our most likely cause? A subarachnoid hemorrhage, a third nerve palsy, a sixth nerve palsy, a fourth nerve palsy, an orbital fracture. There are a lot of things we take a look, and it was vertical double vision, worse at near. We can certainly see, look at the Purkinje, she has a severe hyperdeviation in her right eye. It's worse in left gaze and right head tilt. She clearly had a fourth cranial nerve palsy from trauma. Now, it's all very common in kids because, kids get injured and there's a lot of times it can be congenital. We can see the hyperdeviation worse on the head tilt. And the example here is like this is what I call a double fourth nerve palsy. She has a left fourth nerve palsy and Dolly has a right fourth nerve palsy. So we have a double palsy here. Now, it comes out the back of the brain, the midbrain, and decussates in the anterior medullary bellum. So right is left, left is right, goes around the brainstem. It's out there, it's exposed, it's very long. It's a longest course compared to 6 and compared to 3. 6 and 3, they're relatively protected. It takes a lot of trauma to get a 6 or a third nerve trauma, a lot of trauma. You don't need much trauma here. It could be contra-coup trauma. You don't have to be hitting the head, hitting the eye. You can fall on your buttocks on the ice and get this, follow ice skating and have one of these happen. Because of the course and its exposure, it's the one that's most prone to trauma. Now, sometimes the long-standing ones can present with double vision from decompensation. I mean, look at old photographs. I walk in and they got a head tilt. I know they got a fourth nerve palsy in there. You can see, she's just tilting her head and she doesn't have a torticollis of her spine. Our rule of 40, 30, 20, 10. 40% are traumatic, 30% are idiopathic, 20% are ischemic vascular, and about 10% of the time you got a CNS lesion of some sort. So automatically, you've got about 90% chance that this is going to have a good outcome. Only about 10% of these are actually kind of bad. So managing fourth nerve palsy, if they're isolated and non-traumatic, look for ischemic diseases. Remember, non-ischemic causes of non-traumatic fourths are kind of rare. Look for evidence of decompensation. Sometimes their vergences, the vertical vergences are really, really strong because they're trying to keep their eyes together. You look at the old photos for the compensatory head tilt. Now, as I talked about, traumatic fourth nerve palsy is common. It doesn't have to be a lot of trauma, but third and sixth is uncommon because they're in here. They're very protected within the brain. This is kind of exposed along the side and the tentorium. It can get injured. You need a lot of trauma to get a sixth or a third nerve palsy. In fact, the last traumatic sixth nerve palsy that I can recall seeing was a young adult who was assaulted with a cinder block, got hit in the skull with a cinder block. On imaging, he actually had a piece of cinder block still buried in his skull with an abscess. A lot of trauma. Now, when does this become a nightmare? 73-year-old male, it's actually one of my first patients I saw in my new practice, comes in with a new onset vertical double vision. He had a fourth nerve palsy on the left side. 2 prism diopter based on, perfect. Worked really well. Fresnel prism will be his friend. But he also said, Doc, I noticed my gripper is off. Like, I don't have a grip on my left hand. Hemiparesis. Okay. Medical history, treated for lung cancer, currently in remission, but on maintenance chemotherapy. Okay, something new. Fourth, complicated hemiparesis, history of cancer. This is probably the only fourth nerve palsy I ever neuro-imaged. I saw him on a Thursday. By Monday, he was in the hospice because of brain metastases.
So another way we can say that, Joe, it's not isolated then.
Exactly.
Right. So he's got something. That's that something else that we talk about. He's got that fourth nerve, but he's got that gripper that's off. And it doesn't have to be the eye, right? It doesn't have to be the face. He's talking about his hand. That's 2 things. That's not isolated anymore.
And even more important is cancer.
Right.
and relatively fresh cancer. Now, there's a big difference between a woman treated 25 years ago with mastectomy for breast cancer and a man treated last year for prostate cancer. But cancer is still cancer. Never diagnose idiopathic or ischemic anything in a patient with a history of cancer to rule out that it's cancer causing it. Now, I'm going to give you my ode to vertical double vision. When the patient sees double up and down, it's rarely caused a frown. Look for a tilt and prove it's old. And remember, vertical divergences will be bold. It's a fourth until proven otherwise. Trauma, congenital, idiopathic, you should surmise. But if it's not a fourth and it's new, laying back, it's probably askew. And that's an entirely different lecture that we're not going to get into tonight. Here's a chronic red eye. Beware the chronic red eye. Horizontal double vision and far left gaze. I think she was a 47, I did cut this out. She was a 47-year-old female, horizontal double vision and far left gaze. 2020, she's newly diagnosed with diabetes. She has a left abduction deficit and far left gaze. A little bit of injection of the eye, but nothing that was that concerning to me. Pressure is 14 and 16. Fundus was normal. Diagnosis, presumptive left vasculogenic sixth nerve palsy. Plan, let's monitor. You're going to maybe get worse in a week. We'll worry about things and see how it progresses. Comes back a week later, marked worsening of her double vision. Now, if he doesn't move past midline, that's not concerning, but her eye was a lot redder and her pressure was now fairly asymmetric. And I look in, and she has some congestion of the optic nerve, some vascular tortuosity, and she kind of looks like this. Now, what do we see here is the dilated corkscrew vessels. They're going to the limbus and turning backwards outward to call Omega's loop. We have clear intervening conjunctiva. Look at this, learn this, live this, love this. Nothing else looks like this. CT scan, she has a markedly engorged superior ophthalmic vein, and she has a carotid cavernous sinus fistula. Now, the cavernous sinus is
Joe, show that vein again.
Yeah.
That's a great picture. And we don't look at these all the time. So show the other eye where it's normal, nothing there, right?
But with contrast, we have engorgement of the superior ophthalmic vein and of the cavernous sinus as well.
And so what's happening here is the blood is filling up, right? Arterial blood is filling and ballooning that up. Is that what's happening there?
And because these valves or these veins are valveless, blood can regurgitate backwards.
So there's arterial blood in there is what I want to point out to everyone. There's just kind of blowing that up because it's a high pressure system. Okay.
So this anatomy, this trabeculated venous cavern that has the third nerve, fourth nerve, sixth nerve, first division of the fifth nerve, oculus sympathetics, and the internal carotid artery. A lot of stuff goes through there. And it's going to drain the eye and add next by the inferior and superior ophthalmic vein to the petrosal sinuses and the jugular vein. Officially is a rupture of the artery itself going through the internal carotid or one of the small meningeal branches, the meningohypophyseal, mechanicals capsular artery, or the inferior cavernous artery. So as Greg said, it's mixing high pressure arterial oxygenated blood in the low pressure deoxygenated venous system. And that's what I'm just showing you here is blood is draining this direction, is draining here into the cavernous sinus, kind of fills up and goes out to the petrosal sinuses. The internal carotid artery is going through if it starts to leak, blood will go in that direction and that direction, and it will regurgitate back. Here we have 6, we have 4, we have 3, we have V1, we have the internal carotid artery right there going through cavernous sinus. If this were to rupture, that's a very, very direct high pressure system. Many times, one of these small little dural branches will start to leak, and blood kind of trickles out in there and fills that area. So blood will get in there and will start to regurgitate backwards. Now, is this a fatal condition? No. We have the arterial blood in the venous system. Now, if this vessel ruptured here, it's death. It ruptures here, it's fistula. So they can be high flow, low flow, direct or indirect. They can be spontaneous or traumatic. This is an example of a traumatic cavernous sinus fistula. These are bad traumas. They're usually ER traumas, motor vehicle accidents, assault, motorcycle accidents. I know one case where a man got hit, he got into an argument with his girlfriend. She hit him in the head with a bowling ball. Never argue with women who bowl. That's what happened to him. These are the more that are gonna sneak into our offices. The chronic red eye. They've been like this for several months. And they come in what I call with bag-o meds. They've got 2 antibiotics, 3 steroids, 2 antihistamines, and about 6 artificial tears, all being treated for this chronic red eye that just doesn't resolve. But the dilated corkscrew tortuosity is very, very characteristic. And you have good, clear intervening conjunctiva. So there's going to be orbital congestion. And the big ones, they often can have a pulsatile proptosis. The little ones, the spontaneous ones, generally do not. Corneal exposure is a possibility. Arterialization of the conjunctival vessels is very characteristic. They might hear their heartbeat in their eye. They can have myopathies and cranial neuropathies with double vision and a secondary glaucoma because the episcleral venous pressure will elevate. It's very, very difficult to treat that. Usually only the prostaglandin analogs really seem to work there. So they're vision threatening, but not necessarily life threatening. The low flow ones. Now, there have been cases where the high flow fistulas, you got really this kind of situation going on here. They can develop a fatal epitaxis, actually bleed out through their nose.
So
Now,
Joe, let's talk about that real quick. Kind of, we always talk about it in glaucoma, right? It goes, it's from the posterior chamber through the pupil, anterior chamber, through the trabecular meshwork, through Schlemm's canal, and then into a collector channel. From the collector channel to the venous system to the superior and inferior venous system, and then into the cavernous sinus. That's how the aqueous drains out.
Yeah, into the episcleral venous plexus, into the superior ophthalmic vessels. Yes, that's exactly how it is. Now, one thing that you can always look for if you're ever wanting to put a gonial lens on, you'll see blood in Schlemm's canal. Spontaneous ones, when the little ones rupture, like the little branches rupture, they tend to resolve on their own given time. And most of the time, they are just observed. Now, I will say that today, with all the advances in catheterization and microembolic procedures, they can all be embolized with a catheter. But one thing that has been advocated is have them compress the carotid artery on that side with their contralateral hand and, try to create like a turbulent blood flow. And that can do it. These have actually been shown to close up the low flow fistulas. They have been shown to close up over after air travel. Changing cabin pressure was enough to seal them off. So always beware of that chronic red eye. We have dilated and tortuous episcleral vessels that go to the limbus and back. We call these omega loops. You've got this clear conjunctiva in there, and a red eye that doesn't respond to treatment. So what I call bag-o meds. Here's Greg. You have co-managed MIGS procedures, correct?
I have, yes.
How often have you seen hyphema after, let's say, an eye stent?
I've seen it. It's not common. It's not like 100% or 90%, but it can happen. Yeah, I've seen it after hooked dual blades.
How much blood how much hyphema do you see?
Not much. I've seen, I've seen maybe I don't know. Yeah, the worst one I've ever seen was, almost looked like like a hyphema but it's never been an 8-ball hyphema. A little bit of blood, sometimes a micro hyphema.
Mhm.
So
So I'm in my new practice, and I'm on call. Maybe one of the first times I was on call, and I get a call in the morning, before our offices open up, and a person had cataract surgery the day before, and he's already scheduled for a 1-day post-op, and said that his eye is all bloody and he can't see. All right, so what I always do is I say, send me a picture. So he sends me his picture, and this is a person under a cataract surgery with an eye stent. And he said, when he said his eye is all bloody, I mean, darn it, he was right. I mean, he said he's beginning to see now, but he had about a 50% hemorrhage, and he might have had an 8-ball hemorrhage earlier. And what do you notice there, Greg? Look at those vessels.
Yep.
So I called the surgeon and the OD in the practice who was co-manager and said, something happened. Either we put an eye stent into an eye with a cavernous sinus fistula, or we put an eye stent in and the patient developed a cavernous sinus fistula, and glug, 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 it fills up with blood. Because you don't get that much hemorrhage. You don't get an 8-ball hemorrhage from an eye stent. And they said, here's the picture. This is my suspicion. Good luck, guys. Let me know how it turns out. So
I think that's a great case, Joe. I think that, I think it is that they had the cavernous sinus fistula. You opened up the connection, right? We just talked about the blood is now back into the collector channel. It's being held out by the trabecular meshwork. Now you put an eye stent in there. Now the blood's leaking in. So it just kind of.
I wasn't there. I don't know. I'm hoping we didn't put an eye stent into an eye with a fistula. I'm hoping the fistula developed
right
spontaneously. Damn the bad luck.
Yeah.
Well, I'd happy to remember everything is my ode to a fistula. Beware the chronic red eye. It isn't infected, inflamed, or dry. When corkscrew vessel make the eye red and the patient has bagomed, the problem is deep and arterial blood has begun to seep. Your first fistula you will always miss, but your second case you will never be remiss. You always miss your first one and never miss the second.
Yeah, it was me. I did it. I missed my first one. Treating him like you said, bag of meds, and then, geez, oh man, that's what it was. So yeah, it's your poem your ode is accurate. So
I'm going to land this with a tale of two optic nerves. And I think there are no polling questions, but there will be some chat time for us. Optic nerve number 1, 72-year-old woman noticed a darkness in her right eye of unknown duration. Medical history: asthma, hyperlipidemia, psoriasis, has a history of herpes, uses Valtrex, Flonase, and Otezla. She's 2025, 2020 with an afferent defect in the right eye. And she looks like this. Take a look. OCT is all good. Optic nerve is good. Field's good. Optic nerve pale. We have an inferior arcuate defect. Hey, put this in the chat. Who's come across a case like this before? Where you look in there and you got optic atrophy, and you got no bloody idea what it is. Anybody ever see that? Greg, have you ever come across that?
I have, and probably already in 2023.
So nobody wants to share. They haven't seen that. All right, 72 years old, 2025. Kind of a darkness, APD. We have disc pallor. We have field loss. What do you do next? Hey, put it in the chat room. Now I want you all to participate. Give me something here. What do we do next? Imaging, okay. Specifically, what do we image? I hear MS. Was it sudden? No. Color test, sure. Send the ER, get a SED rate. Order blood work. What blood work? Neuroimaging, no pain, eye movement, no temporal arteritis, no pain, no sudden loss. Neuroimaging, but what do we neuroimage? See SED rate, okay. People are putting a lot of stuff in there. Imaging, I say non-arteritic ischemic neuropathy, meningioma, CBC, platelets, MRI brain orbits with and without contrast. Imaging. Okay, the answer, yes. Yeah, pretty good. I mean, Greg, is this easy in any way? Is there anything
No.
obvious to you here?
No, I mean, right. I mean, you got the age involved, you got the darkness, you got an APD.
Mhm.
You know, it's yes.
So we have to look at everything. We have to look for compression, orbits and chiasm, with and without contrast, fat suppression. We need a brain MRI. We need a lot of serological evaluation. We have to look for all the systemic causes of optic atrophy. Is this easy? No, this is a nightmare. Okay, this case is a nightmare. It's a lot of work. You have a lot of serology, which I do work with primary care physicians. I tell them what to order. We work together on that. I order the imaging myself on patients like this. No jaw claudication. Imaging in prayers, not bad. Hail Mary, very good. Well, let me share a case. This is a tale of two optic nerve. Here's optic nerve number 2. 72-year-old woman who has a new onset of flashing lights, probably in the right eye, maybe OU, she can't tell. But she doesn't have any floaters. And Greg, when you hear flashes, what do you think of? Where are we going with this?
Yeah, I mean, you know, you're trying to, 72-year-old, you're thinking vitreous, but is this more
Yeah.
of a scintillating scotoma, or is this
Mhm.
more kind of that kind of PVD 72-year-old, maybe a little bit more questioning on those types of flashes, one eye, both eyes. But
Yeah, Michael Clyde, I agree. That you got to consider that. This was seen by one of my colleagues in my practice, and she was thinking the same thing. Flashlights, dilate the patient, take a look. You're looking for retina. 20/20 each eye, no afferent defect, color confrontation fields full. She's a multifocal IOL patient, very successful. History of asthma, hyperlipidemia. She also uses Valtrex, and there are her optic nerves. Yikes.
yep, there's a PVD
So
right there.
Yep. So what are we seeing there? There's a massively engorged optic nerve. Some hemorrhages about there. The other eye looks fine. She's actually 20/20 in this eye, and there's no afferent defect. Now, what are we going to do here? Hint, she has been to a Lyme endemic area in the last several months. So we have a very edematous nerve. Function is pretty good. Now, I will tell you, I have seen patients with central retinal vein occlusions complain of flashing lights.
Mhm.
But we don't have an especially dilated tortuosity to the veins that we can see. But we've got a lot of things going on here. Now what do we do? Oh, here's her visual fields, and here is her OCT. Visual fields are essentially normal. OCT is normal, vision's normal, pupil's normal, optic nerve is not normal. What next? Put in the chat. Possible, Lyme titus, swollen nerve, temporal arteritis, disc edema. No symptoms of temporal arteritis. Function is actually very good. And it's not a pale swelling. Lyme, blood panel with Lyme, possibly acute neuropathy, vision is good, pupils normal. Yep, that, Jerry, you make a very good point. Not an easy case. What else are we going to do? Spinal pressure, glioma, labs and neuroimaging. Okay, I agree. Yeah, the answer, yes. Very good. Yes, I agree. MRA, CTA, crowded cavernous sinus fistula. No, we're not going to have two in a row, Stara. You're not allowed to diagnose what you just learned tonight and last week. So a lot of things that we can do. All right. We got to consider infection. Presumptive diagnosis, infections, perineuritis. Swollen nerve, good visual function. You probably have a perineuritis, which is infectious. You have swelling of the nerve sheath. MRI brain, MRI orbits and chiasm with and without contrast, with fat suppression, because we're looking at the optic nerve. Unfortunately for me, it's normal. You know, Greg, I've had a number of cases where the MRI has not agreed with my diagnosis. I think I'm going to stop getting MRIs.
Mhm.
So I do. I asked the neuroradiologist, can you please take a look at that again? I really think this is a perineuritis, and look for optic nerve sheath enlargement in perineuritis. It's got to be Lyme disease or syphilis. He looks normal. Said, no, it's just not there. So now on to serology, working with a PCP. CBC, CEDRIC, CRP, ANA, RPR, AP, FTABS, ACE, zoster, rubella, toxoplasmosis, Lyme, Bartonella, Henselane quintana. All those panels were normal. The only abnormalities were simplex IgG and IgM. She knows that she's already on Valtrex. We know that. And she has Epstein-Barr titers, which subsequently were normal. And that was probably an old infection and not contributory. I can tell you when I worked with the internist, I got the imaging. I thought presumptively I knew what it was. Imaging came back perfectly normal. So I spoke with the internist and I was talking to him about infection. He said, yeah, there's something I remember that begins with a T, I think, yes, a toxoplasmosis. So I gave him all of this to order and all came back negative. Now, the tail of two optic nerves, it's the same patient. Okay, same patient. Sometimes we see the patient, they look like this. Sometimes we see them like this. What we don't know is the patient who looks like this may have looked like this at one time. The patient you see that looks like this often ends up like this. No cause, no treatment, no effect. There's nothing we can do. She was initially 20/20. She's 20/25. She knows she's got a little bit of a field defect, but otherwise she's fairly well functional. So this is actually the same patient. I'm just showing you from two different directions. I went backwards, then forwards. Sometimes you look at this and we see where did that come from? It came from something like this at one time. What is this often going to end up with? Something like this. Here's a disclosure. Optic nerve diseases sometimes often don't end well. Craig, I think that's enough. I got a little bit left over, but it's not really anything that's all that good. So I think I'm going to turn it back over and look at the chat. COVID vaccine reaction. Good question. No, I don't think so. In fact, I don't think that, I don't know if we had the vaccine, to be honest with you. And yes, Michael, yeah, there was optic nerve atrophy there.
Any other questions that you saw in there, Joe?
Let's see. Pseudofoster Kennedy, optic nerve atrophy. No pseudo optic nerve. The other eye looked absolutely normal. It wasn't ischemic neuropathy. It was a huge I don't know. And she's got a great personality and sense of everything. She said, geez, you tested me for everything, didn't you? I said, well, no, not West. I didn't test you for the West Nile virus. But we looked at everything possible. And we found nothing. That's
Well,
it.
Joe, thank you very much. I certainly know since the years of knowing you that my neuro has certainly got more comfortable in the office, relying on you less and less, but thank you for that. And it's all comes from these types of lectures. So you did a great job. All the questions have been answered. Thank you very much for doing neuro-op cases and complexities, the best of the rest. This was a synchronous virtual course. Thanks everyone for attending. You're starting to get your virtual round of applause there. That will end the CE.